Okay, so I believe we can begin. I'd like to first extend a very warm welcome to all the audience members who joined us this afternoon and evening in Austria. Thank you so much for taking the time to join us in this Joint Academy panel on healthy societies. Before we begin, I'd like to also thank the Austrian Academy of Sciences and the Royal Society of Canada, as well as our esteemed panelists, who I will introduce in a moment, for making this session possible. Unfortunately, Dr. Veronica Fexel, who is on the agenda, is unable to join us today. She had her COVID vaccination and could not be here. First, I'll introduce myself. My name is Candice Nikiforek, and I'm happy to host this session today. I am a professor in public health at the University of Alberta in Canada, and I also serve as the director for the Centre for Healthy Communities at the School of Public Health at the University of Alberta. I am a member of the Royal Society of Canada's College of New Scholars, Artists and Scientists, and my research area focuses on public policy and healthy communities, and most of my work takes the form of natural experiments and population health interventions in collaboration with partners working in practice and policy across a variety of sectors. And as I said, I'm very, very pleased to be serving as the chair for today's session, and I really look forward to our exchange of ideas. So why don't I begin with a brief introduction of each of our panelists, and then after I've said a few words about each of you, I will ask that you in turn tell us more about yourselves and your research related to healthy societies. So to begin, I'd like to introduce Dr. Marc Louis. He is the head of the research group Health and Longevity at the Vienna Institute of Demography of the Austrian Academy of Sciences, and also the director of the German-Austrian Cloister Study. He is highly experienced in developing and teaching courses for undergraduate, master's, and doctoral students, and has taught basic and specialized courses in demography at several prominent universities, including the Vienna University of Economics and Business for the last number of years. He has received several awards in population studies and demographics, as well as funding in those areas. And in 2011, he was elected to the Austrian Academy of Sciences as a member of the Young Academy, and in 2016 as a corresponding member of the Division of Humanities and Social Sciences. Since 2014, he is also a member of the Commission for Science Ethics of the Austrian Academy of Sciences, and he has served as Secretary General from 2012 to 2016. Marc's research is focused on differentials in health and longevity. This is a really critical area. But these corresponding topics involve differences between specific subpopulations, such as women and men or socioeconomic status groups, as well as differences between countries or smaller regional units, with a special focus on differences between and within Eastern and Western Europe. The specific characteristics of his research lie in the introduction of new hypotheses to better understand the complex mechanisms behind healthy aging, and the development of innovative methods to estimate life expectancy and health expectancy for subpopulations. Next, I'd like to introduce Dr. Judith Simon, who is professor and head of the Department of Health Economics and deputy head of the Center for Public Health at the Medical University of Vienna in Austria. She also coordinates the doctoral program in public health and leads the Health Economics Program Lean at the Ludwig Boltzmann Institute of Applied Diagnostics. He also remains a visiting professor of cognitive health economics at the Department of Psychiatry and research associate at the Health Economics Research Center. He has a multidisciplinary background in medicine, health economics, and public health with relevant academic degrees from Hungary and the UK. She is a fellow of the UK Faculty of Public Health through distinction, founding board member of the ISPOR Austria chapter, and sits on several national and international advisory boards, including Statistics Austria, the Austrian Public Health Institute, and the COVID-19 Task Force of ASTFER. Professor Simon's main expertise includes methodological and applied health economic evaluation research, capability outcome studies, cost and cost of illness analyses, health services and systems research, clinical guideline development, and evidence syntheses. Currently, she coordinates the ongoing EU H2020 Pecunia project to develop improved methods for mental and health economic evaluations, is principal investigator on several studies related to capability of well-being and mental health and comorbidity research, and also leads the health economics working package of the 8th 2020 iLive end-of-life care project and several mental health trials. I do not know when you sleep. Last and certainly
Never.
not least, I would like to introduce Dr. Susan Horton, who is a professor of global health economics at the University of Waterloo, a fellow of the Canadian Academy of Health Sciences, and a fellow of the Royal Society of Canada, also another non-sleeper. Her earlier work on the economics of nutrition is well known, and more recently she has worked on non-communicable disease in low and middle income countries. She is currently Deputy Chair of the New Lancet Commission on Diagnostics, with an expected publication early fall of this year. She has worked in more than 20 low and middle income countries, including Kenya, Tanzania, and Ghana, and has consulted for over a dozen United Nations organizations, international development banks, and international research organizations. And according to Google Scholar, there have been more than 20,000 citations of her work to date. Audience members, before we begin, I'd like to remind you that you are most welcome to post your questions or comments in the Q&A or F&A box at the bottom of your screen at any time, and I will be posing your questions to the panel after we begin our discussion. So now, before we get into our discussion questions, may I ask each of you in turn to tell us a little more about yourself and your research in your opening remarks, and we'll use the same order as the introduction. Thank you.
Yeah, thank you very much. So first, of course, thanks to the organizers for having me here, for inviting me here. I feel very honored and I'm really happy to be here. And thank you, Madam Chair, very much for this kind introduction. And I'm not sure what I can add. So you told already so much, maybe even too much about my background and my work. Maybe I can just summarize it again. As you said, my background is in demography and geography. I studied geography, but since I'm active in science, I'm working in demographic research with a focus on health and longevity. And as you said, the main aim of my research is to disentangle the complex causation of healthy aging. So this very general term. So let's say what I want to better understand the factors and the causal mechanisms that make some people or groups of people living longer and healthier than others. So the existing knowledge in this area is still very incomplete. You can imagine it like a very huge jigsaw puzzle of which many, albeit not all, pieces are at hand. But for most of them, we do not know yet the right picture or the right position inside this overall picture of this puzzle. And yeah, so this is in principle the main aim of our research, of what I always had since the beginning, that I try to find new pieces and above all to get a better impression of this overall picture of healthy aging. Yeah, as a demographer, I'm working, of course, mainly with population data, statistics from populations, for populations of mortality, causes of death, health surveys. But we are also collecting own data. You mentioned already our German-Austrian cloister study, what is our largest project, where we study the health and longevity of Catholic order members. And I think this is a very exciting project. Also, you mentioned that your research interest, Madam Chair, is also in the area of natural experiments. I think this is a classical natural experiment to investigate how this specific living conditions of order members. And for me as demographer, most interestingly, the fact that they are not as heterogeneous as any other group in the usual population with regard to the living conditions, the access to medical care, nutrition, and so on. So it's a group of women and men that is very homogeneous with regard to many aspects, and to investigate there the effect of sex, for example, so the gender differences in health and longevity, effects of education, so how these effects come out in a population which is very homogeneous with a lot of factors. So I think this is very exciting. So yeah, as a demographer, I'm working, of course, by definition on societies and with a background in health and longevity. So I'm working much on healthy societies. I think that this is the reason why I was invited to this panel, and I hope that I can contribute to the discussion and maybe also bring some interesting perspectives or views from my background. So thank you very much again for the invitation.
Thank you, Dr. Louis. Professor Simon, would you like to go next?
Yes, I also would like to thank very much for this very detailed introduction, very difficult to add, and also to the organizers. I'm very happy to be here tonight and get to know not just the panelists and the views, but hopefully also the audience's views with questions about healthy society. My background, as you already mentioned, is quite multidimensional. So I studied medicine and economics, and then my academic background is in health economics and public health. More in terms of the research we are doing beside the economic evaluation that is kind of running in the background, and it's a methodological approach to looking at value of different treatment options. I work a lot in mental health economics, and not just in economic evaluations, but really cost of illness, looking at what influences the well-being and the quality of life of people with mental problems, how the different treatment options influence this, and some other areas beside mental health are palliative care, end-of-life care, personalized medicine, cancer area, and previously non-communicable diseases, and of course public health. What I think for today possibly is the most interesting on my side to bring to the panel are two aspects of the work. The one is the measurement aspect, which is very much a big part of my job, to measure outcomes, both for economic evaluations and generally, and how best to measure outcomes. And within this field, the capabilities approach, which I hope we will have the opportunity to a little bit discuss, how to bring this broader well-being quality of life assessment to health rather than just a basic health status. And another project I previously worked, another European one, was on health information and indicators for health and health service performance assessment and health system performance assessment. And here we also found some very interesting points I think we could bring to healthy societies. So it's one aspect of what influences health, but I think it's also very important what we mean by health, because depending on this, we might get to very different conclusions. So this is what I would like to bring today, and I very much look forward to the discussion. Thank you.
Thank you, Professor Simon. And Professor Horton?
Yes, it's a great pleasure to participate in this panel with such a distinguished group. And also, I have a very deep fondness in my heart for Austria. We had an Austrian pen pal when I was young, and so I spent a very formative summer when I was 16 in Vienna and in Niederösterreich and in Carinthia. And so I've only had the chance to go back to visit once, but I'm enjoying visiting your beautiful country by distance today. So my work is primarily on global health, and obviously I work a lot on inequality because I'm thinking about the needs of people in the poorest countries. But today I'm going to talk less about that, but more to try and focus on the very interesting questions that Professor Nikiforuk raised. And amongst the things, in addition to the things she mentioned, I work on, this year I am the policy and economics theme lead for something called Can COVID in Canada, which is trying to, in real time, very quickly to assemble expertise to support the government and its implementation of policies during these very, very challenging times. So it's been very interesting for me to learn about health in high-income countries. So in preparation for the panel, focusing on the questions that Dr. Nikiforuk raised, it caused me to think about healthy societies in a more abstract way. And the thing that struck me was that in the past, I would have said Canada is a very healthy society, in the main, the biggest obstacle being the health of our indigenous populations who live in very remote and undeserved areas. But I would say that the COVID crisis, COVID pandemic, has been a great revealer. So that's not my phrase, but from the literature, people talked about COVID being a great leveler. One of the assistants to Boris Johnson in the UK at the start of the pandemic, when Boris Johnson went to hospital, said, yes, this virus knows no differences, it affects everybody. But we know that's not true. We then subsequently have been just deluged in statistics showing how it's been much worse for older people than for younger people. And it's had very racialized impacts. I haven't seen statistics on Austria, but I would bet that in much of Central Europe, the issues between immigrant population and those whose families have been long established in Europe are probably quite serious. For sure, you've all seen what's happened in the US and the dramatic differences between healthiness of the white population versus Hispanic population and people of color. And it's probably the same in Canada. And one of the things that occurred to me as I was reading these very interesting questions is that in the US, they are able to produce these statistics about health of racialized populations because they collect those data. And in Canada, because of our different ethos and our emphasis on multiculturalism, we've been quite cautious about publishing race-based data because it has the possibility of reinforcing stereotypes or creating stereotypes. I'm sure you've all heard about the China virus, which the former president in the US said. And these things are very pejorative, and you wonder how much that feeds into events like yesterday. I think it was yesterday or the day before, when a young man shot to death 8 women, including 6 Asian women. Anyway, so these were some of the issues that came to my head as I was thinking about the questions. But I feel ill-equipped compared to my esteemed colleagues in some of the more technical side of this and the questions about the skills needed in the next generation. Anyway, I look forward to our discussion. Thanks for inviting me.
Thank you all so much. And so why don't we move into our discussion of the questions? And by way of introduction of the topic to the participants, I just want to remind everyone that, our focus on healthy societies is intentionally broad and really trying to understand that when we're thinking about health and health outcomes, we can't do that without also thinking about their interconnections with socioeconomic and political systems, natural systems when we think about One Health, for example, as well as the social infrastructure, speaking to equity and structural barriers and built form impacts on health. And so this forces us, when we're thinking about the concept of healthy societies, to think about things not only from health outcomes point of view, but from economic viability, ecological sustainability, community resiliency, inclusion and exclusion, and social vitality. And so this has phenomenal implications for measurement and methods for measurement, for understanding health, and for understanding how to include the voices of citizens who may be experiencing our society and outcomes of our societal forces in very, very different ways. And so into that, we know that the health of societies is a fundamental and critical determinant of our ability to effectively respond to the rapid escalating physical, mental, societal, and environmental health issues facing us today, which, as you've all pointed out, is earmarked and emphasized by COVID-19. So recognizing that, my comments and your introductions are only a very small slice of the complexity that we consider when we think about healthy societies. Panelists, I'd love if you could share with us, please, your perspectives on what makes a society healthy or unhealthy. And I will call on a volunteer to begin.
So shall we start in the same order, I guess, as before? Okay.
Great, Dr. Louis, please.
Yeah, so thanks. So to start with this very general question, because I think this is a very nice for warming up. And what makes a society a healthy society? I would say, so also to start very generally, that a healthy society is a society with the overall health condition, let's say, that is as good as possible, yeah, to make it very simple. And then of course the question starts, how do we measure this, or what kind of scale can we use to see what does it mean if a population is healthy or not? And I think that in this context, demographers use a very interesting and very useful concept, and this is the concept of life years. So when you measure health condition in terms of life years, so life years overall means the total number of life years, or even more important, the number of healthy life years. And then I would say that, so to put it very simple, that a healthy society is characterized first of all by a high total number of life years, together with, so that's not everything, together with a high number of healthy life years. So in other words, that the proportion of healthy life years is also very high. So this would be a very general answer to your very general question. And of course, I put it very simple. So when we go into practice, it is not as simple as it sounds now. And Professor Simon already mentioned some of the problems that start at this point and that become more and more complex, starting with the definition of health. So what is health? How do we understand health? But also, how do we calculate this? So in the demographic approach, this calculation of life years and the integration of health is very, very complicated. But I suspect that we go into more detail into these issues later in the discussion, because I'm also happy to discuss and contribute in this, because similar to Professor Simon, we are also in the moment working on a very big project exactly on this question. So how to estimate healthy life years and what are the problems in the estimation itself. But as I said, I think this slate is of very generally, to sum up, I think a healthy society is characterized by a high number of total life years and a high proportion of healthy life years. Yeah.
Thank you. Then I take over. On my side, what I would like to mention, I think, as the first step, that many people may not be aware, although we already introduced it and we discussed that beside healthcare, there are many other broader socioeconomic factors, cultural factors, physical environment, lifestyle, etc., plus all the individual factors that influence health. Nevertheless, people think that if we spend more on healthcare, this means that the population health will improve, and there is a kind of direct linkage here. So what the data, of course, are not proving this, and there is a good reason for that. And I put down as my main statement for today is numbers do not lie, but can be easily misrepresented and misinterpreted, and are often not comparable between settings. And the devil, as always, lies in the details. And what I would like to bring here, that there have been many studies looking at that actually what is the contribution of healthcare to a healthy society, to a health status of a population. And we find here a range of estimates between about 15 to 43%, depending on which study we look at. So we can see that actually the bigger bulk of the overall population health is coming not from the healthcare, but from these broader non-healthcare determinants. And as it was already mentioned by Dr. Louis, we are looking at the overall population health. This is very important. What is the average? But we can see, for example, the US is the best example. They have a wonderful healthcare system in terms of you can get anything you want, very high quality. But if you look at the overall population health achievement in terms of life expectancy, for example, or the distribution of this health within the population, then you find very big inequalities. And so beyond the overall health, the distribution, the equity is another very important aspect. And as a health economist, I also have to mention that at some point we have to think also about the sustainability and efficiency. So how much, where we best invest governmental money is it best to try to invest more and more in the healthcare system, or is it also maybe to think about more in education, etc.? And the most important for me is this investment in healthcare expenditure is increasing everywhere in the world tremendously. This is not new information. But what remains stable is the spending on prevention. And another very important figure maybe for tonight is we only spend in the EU, and I would be very interested to know about Canada in case you have this figure. In the EU, we spend about 2 to 3% of health expenditure on prevention, on public health. And the rest on clinical care. And it would be interesting to know, I think if we talk about healthy societies, this is something we should tremendously change. And this is pre-COVID time. Obviously, I'm not talking now about the last 1 year. Thank you.
Thank you, Professor Simon. And Professor Horton.
Yeah, so perhaps because the three of us are coming from demography and economics, we've interpreted the question a little bit more narrowly than you would. So I'm going to say some things, but I'm also going to invite you actually at the end of our brief introduction to talk about the broader issues. I don't work on One Health, but that's the idea where everything is connected: the environmental health, planetary health, animal health, people's health. I think we haven't touched on things like the fact that COVID came out as one of these zoonotic diseases and to do with our, probably unnatural links to the environment, the way we have done things in the environment. Nevertheless, my own focus, because I'm a more simple economist, is that societal health is what generates healthy populations, because that's relatively easier to measure. I think these very multidisciplinary things are much harder to measure and much harder to theorize how we can make improvements. So, and one thing that struck me is, to do with what happens in when things are relatively unchanging, and then what happens in an era where there are sudden, very large dislocations. So, I think we had been able to, achieve, in Canada at least, achieve reasonable levels of population health, high life expectancy, because we have a more socialized medical system compared to our neighbors in the US. We don't spend as much on health as in the US, but we do try to address more spending to inequities. I'm sorry, I don't know, Judith, what we spend on preventive health here, but almost certainly it's probably similar to Austria. But it's also hard to measure because some of the expenditure on prevention doesn't appear in the health sector at all. If you want to reduce road traffic accidents, you don't spend health money. I mean, a little bit maybe in mandating motorcycle helmet laws, but you also build roads in different ways. You don't make the access roads so dangerous. So it's quite difficult to measure the expenditure on prevention. What I can say is from my experience in working in low-income countries is that there's much more emphasis on prevention, vaccines, etc. And, as an economist, I would say you can get a lot more health for your money by doing that. And so my interests in diagnostics currently are related to the fact that if you spend money on treating illnesses that you're not sure people have, you're wasting money. Or in fact, you may be damaging their health by not finding what the real cause of their disease is. So in the work on the Lancet Commission on Diagnostics, we noticed that in the Sustainable Development Goals, the World Health Organization talks about access to vaccines and medicines, but that's not enough. As we know from COVID, if you don't identify who has this very infectious disease, you're wasting your money by spending money on very expensive treatments for the disease because you're not addressing the problem at the source. So, what else was I going to say on this topic? Oh yeah, one last thing. measurement, and I expect we'll get to this later, yes, I think, of course, I spend a lot of my time thinking about DALY's, disability adjusted life years, because those work quite well for making comparisons across countries, something I'm very much interested in doing in my work. So we're all highly indebted to the global burden of disease work that's done by IHME in Seattle. On the other hand, I would point out that that work can also be somewhat subjective. If you've looked at the global burden of disease as it's been measured over time, back conditions have become suddenly very overwhelming in terms of their negative effect on health. And yes, I'm sure that's the case. As I get older, I realize, yes, it's very important to take care of your back, but at the same time, I think it's also vulnerable to being lobbied. So, there are some advantages to mortality over some of these more sophisticated synthetic measures. So, sorry, I haven't done this very clearly, but these are some interesting comments that were sparked to me from your introduction. And please, Dr. Nikiforuk, I'd like to hear your perspective.
Oh, well, thank you for including me in the conversation. I will be quite brief, but I think you all raise very critical points. And as I listen to you, I think about, in some ways, how my work is quite different. So I'm a health geographer. I have a health geography and social sciences background and came late in my career to public health. And I think for me, the thing that I hear most or think about most is how do we capture those things that occur so far outside of the healthcare sector or even the health system. And we implicate it by saying prevention, but how do we understand what levers impact determinants and root causes in what profound ways? And how do we capture that and understand then, bringing it to an economic conversation, the cost savings to the system over a much longer term, but also how that reorients us to thinking about how we cultivate and invest in and grow a healthy society rather than just measure the state of healthiness in a current moment in time. And this is really difficult to do, I think, when we consider our political cycles are quite short, our funding cycles can be even shorter. There's, in some ways, structural disincentives to be working across jurisdictions or across sectors or across teams in ways that allow us to take a complexity approach to what's fundamentally complex questions. So, I think from the social science perspective, even thinking about things like social isolation or the work around loneliness and health and what that means in the context of a pandemic, or how we understand financial stress and financial security related to long-term impacts on health, or how we understand our investments in early childhood education or concerns for single parents as investments in a healthy society, or how we pay attention to not only our physical infrastructures, our buildings, our roads, our bridges, but also the social infrastructure that allow people to create intergenerational linkages with one another. And how do we capture those investments in a way that helps us understand measures of health more broadly? But I digress, and I'm keeping an eye on the clock. So I want to, leave that with you all and move into our question about, so then how do we measure societal health? I think you all touched on that in your response to the first question, but I think, yes, this is the time to get more technical in terms of thinking about when we measure society health, what in fact are we measuring? Who's left out of those measurements? And how should the information that we capture be used and by whom? And, I invite you to reflect on those things that you wish you could measure and right now, for whatever reason, cannot. I'll leave it there. And maybe, why don't we go in reverse order this time, and Dr. Horton, start with you, and then Dr. Simon and Dr. Louis.
Okay, so how to measure societal health? So I think it goes back to the big theme that occurred to me about COVID, about the great leveler and the great revealer. That because things have been static, in many ways, we have been able to equalize more people's level of health. And then suddenly we have a very disruptive force. And from what we know about technological change, it's the people who are more educated, the people who have, more access to resources, who have more flexibility, who are very quickly able to adapt. And it's other people who are subject to social forces that make it more difficult for them to adapt, who tend to get left behind. So I'm just thinking back, when the HIV epidemic began, it was initially for highly educated, mobile individuals, and suddenly people started dying at universities. But very quickly it shifted from being that kind of a pandemic to a pandemic that then shifted further down in the sort of social hierarchy, income hierarchy, to people who were were less able to either change their behavior or to learn quickly how to access the kinds of treatments that were available, or to protect themselves. And so I think exactly the same thing happened with COVID. Who were the first people in North America who were affected? I think, as far as I know, very early on, it was travelers, people living in New York City who crisscrossed the country, going to conferences, etc. People who went, and the other thing was people going skiing from the UK were badly affected. Apparently there were Chinese wealthy people who went to Italy or some of the resorts in the Alps, and then the disease got quickly transmitted to the UK. So it started out being a disease that affected the educated, the affluent, but then it's very quickly equally changed to being a disease where it's the people who have the least ability to adapt, who have the least resources, who have the most limited flexibility, who are now affected. We see people relying on misinformation from social media. I would assume that that's correlated with education and therefore affecting behavior. Also, people who cannot work from home. We're all lucky, we're all white-collar workers who are able to work remotely. But the people who are delivering the goods to our front door that we want, or bringing the takeout food, or emptying the garbage, etc. All of those people are much less able to resist the infection. And then obviously, I think I mentioned quickly before about race and how that's been a big divided issue, in part because it's so heavily correlated with these other social forces. So I think COVID has revealed a lot about the disadvantages of using aggregates to understand what's going on. And in Canada in particular, since we don't collect race-based statistics on health, and we've been fairly careful not to highlight these race issues, on the one hand, that's perhaps been better than in the US, where you get these stigma developed. But on the other hand, it's not enabled us to keep pace with these racial disadvantages that have been noticed during the COVID epidemic, and perhaps not to respond in as quickly as we should have. Anyway, so those are my quick thoughts on the topic.
Thank you. And Dr. Simon.
Oh, I have a lot of thoughts, and I'm sure I will forget half of them as I start talking, but I will try to reflect. So I fully agree what was just said in one of the last sentences, that aggregates are not very helpful. But life expectancy is a very simple measure, yeah. And for a long time, and still in many cases, we are trying to impact mortality and increase life expectancy. And I think Austria is a country which is the best example that if we look at life expectancy, Austria is doing very well in comparison to other countries, to OECD, EU average. But as soon as you bring in morbidity, then suddenly Austria, when you are assessing the health in terms of healthy life expectancy, we are somewhere very much at the bottom. So there is a big discrepancy depending on how you would judge societal health when you are looking at mortality versus morbidity. And we have a gigantic gender gap in all countries. Women in the EU on average have a 5-year more life expectancy. But what is more striking is the gap because of educational difference. And I think this is very much tapping on Sue's comment that between a very highly educated man or a low education, someone with low education, there is 7 years age gap, life expectancy terms in Austria and in EU. So I think if you want to tackle this, and now with COVID, I believe the gender gap will possibly also change, because we know that COVID is impacting more in terms of mortality for men. But when you think about education, and I think about the next generation, and we are kind of already in the third topic, and I don't want to talk about, I myself have 2 children, and I know what it means to have a background where you can provide technical support for homeschooling, etc. And I know what difference it makes if you have not this family background, and what will this make. So I believe thinking about how to, in the long term, tackle the impact of this pandemic. We have this short term tremendous health impact, but in the long term, this will be very much an economic and a social impact. And we should not forget the young ones. They may not die from COVID, but they will be the ones, I think, tremendously bearing in the long term also the health consequences because of educational gaps and etc. and the inequalities. So I think this would be my point, and I cannot not bring in the topic of mental health, because we did a study in Austria and we found that about 30% of the respondents are suffering from mental health problems that are already at diagnostic levels. Yeah, this is way much more than we had before COVID. And when we looked at people who had already previous mental health illness history, they are actually the ones who are the most impacted in terms of their health, in terms of their well-being, whatever measurement we were using, and we looked at quite a few different ones. And I think we should not forget about these people. They are relying on social contacts. This was another point brought up. And I think what we also saw, that when we measured the social connectivity of these people who answered our questions, then actually the biggest resilience factor, not just for those with mental health problems, but with the others, are actually social connectedness. And I think this is very important. Whatever policy is gonna be brought in by any government in the world, that we even though we need lockups and no one says this, we find ways to that people, especially the very vulnerable ones, can stay connected. And maybe I would then hand over to Dr. Louis with the very last, that the big increase in life expectancy happened over 65 in the past decades. And this is your topic, I believe, and the gender gap is disappearing in this age group. So on my side, it's not my topic, but I would be very interested to see, it seems women are aging worse than men. And what is your maybe take on this?
Yeah, thank you. It's in indeed my main research topic, gender differences in life expectancy and in healthy life years. It's as usual in these discussions, it's very difficult somehow to put everything together that has been mentioned so far. And I made so many notes already what I would like to say. I hope I do not forget your question about the differences in life expectancy between women and men. And there were also so many other aspects I would like to comment on. I'm sure I will forget many of them, but let me try to, okay, I start with your question again, Madam Chair, maybe, and then I try to remember everything I wanted to say. So you started with a question, how should we measure health. So let me start with this, because I think so. This is a question: what indicator can we use? Because it's very important that we have some number or some instrument with which we can first measure health, but also to transport the knowledge that we have to those who use this indicator, what was also part of your question at the beginning. And so I think that when we think of such an indicator that is most useful, then it, first of all, it should have a clear and distinct meaning. So this is what I always think. We also have different indicators for health and different ways of measurement. I always try to find indicators that are very simple to understand and to clear and easy to interpret, and that should also be available for ideally every population, or at least as many as possible. And as we heard also in the discussion, what is very important, and I hope that we can come back to this in the discussion later, that we do not think of the population as a whole, as on the aggregate level. It's very important what's happening in the subgroups and the vulnerable groups. And because the total average is always composed of the health experiences of the subpopulation. So that means an indicator should also be available for the subgroups, that we can also deaggregate our analysis of the health measure. So this brings me again back to the life years concept, because I think that fulfills these requirements, because it has a very clear and real life meaning that can be, according to my experience, really understood by everyone. So of course the scientists, but also the policymakers, the public health officials, but also the general public, most importantly. So also for them, life years, when you speak in terms of life years, this has a very clear meaning. And also according to my experiences with events in the general public, using these life years is also a very good way to transport our insights to the general public. Above all, when we use differentials in life years. So also has been mentioned in the discussion already, differences between women and men, for example. As Professor Simon said, this 5 years, that's really a lot, even larger differences by education groups. So I realized that this helps people start to think about it. So first, this deaggregation to subpopulations helps them to identify with the question, because the more you deaggregate this abstract number of life expectancy or healthy life years to subpopulations, the more people feel part of it and also start thinking about what could be the cause behind. And I think this is a very, very important point here, this presentation of differences, also not only to bring the knowledge to the people, but also to understand why the level is on a certain, between populations of different levels or between times and different levels. So let me make now this again to the issue that we said already, that it's what is health, because when we first, this was about the concept. So what concept might be useful? I think life years is a very helpful concept. And Professor Simon mentioned that life expectancy is very simple. So it's only simple when you do not think about how it is calculated and what it really means, this number. It's just at a first glance, the word is very simple, but the meaning not. But compared to healthy life years, you're right. So it becomes really very, very complicated when you include then the health to this life years concept. And also here, a lot of issues have been mentioned already. And I would like to take up, Professor Simon, this example, what you mentioned with Austria. It's comparatively, in international comparison, very high in terms of the life years, but very low or comparatively low with the healthy life years. Above all, in the European indicator that they use, this healthy life years official indicator. And there's a very interesting episode that I would like to share with you, which I was confronted with in the last years with this indicator, because it is based, so the question is then how do we measure health? And this healthy life years indicator in Europe is based on this, Professor Horton mentioned already, this indicator GALI, so the Global Activity Limitation Indicator. And this is based on the questions, so people are asked in surveys. I'm not sure if I can put it 100% correct now. So during the last 6 months, to what extent have you been limited in activities people usually do because of your health problem, so mental or physical? So it's a very complicated question. There's already one issue. And then the answer categories are I'm not limited, limited but not much, and strongly limited. And health is identified then by the proportion of those who indicate that they are not limited according to this question. And similar to Austria, also Germany was very much even lower than Austria in the statistics for many, many years. So we have in Europe the typical East-West division. So on the top with the highest values, we have the Western European countries, above all Scandinavian countries, and on the bottom, the Central Eastern and Eastern European countries, and Germany was inside. And this was, I'm from Germany, and I was part in some discussion groups about this, a very big issue for Germany that they are in this lowest end. So they try to find out what can be done. Of course, they do not want to be, they want to have a healthier population. And then they looked at the statistics, and then they found a very nice example of a country that had a similar problem, that was Sweden. So Sweden was at the beginning, when this time series started, at the top of Europe, and then it decreased stepwise on place 5 or 6. And then suddenly from one year to the next, it jumped up to place number 1 again, with a very big gaps and very big advantage in healthy life years compared with the place 2. And what Sweden has done is that they did not change the question, but they changed the way how to answer to this question. So I told you that there were these 3 answer categories. So are you limited, not limited, limited but not much, and strongly limited? And so they asked first, are you limited, yes or no? And only for those who indicated that they are limited, then they got the question, to what extent are you limited? And I think, yeah, when you think about this for a moment, it is clear that this makes a very big difference, or at least from my perspective as a German. So we always find something to complain about, and nothing is perfect. And when we have the option to indicate that we are limited but not so strong a little bit, then I think we tend automatically to do the cross here. If we have only the option between yes and no, I think then the probability would be higher to indicate that I have no limitations, because then I would probably think more of the strong problem. So just to be short, what happened, Germany adopted the same question, so the same strategy to separate this Gali question into 2. And what happened, it was in 2015, you can look at the numbers. Germany jumped up from, I think, place 16 to place number 5, and now they are on the top. So this shows to some extent also how absurd this can be, the statistics. So how sensitive, above all, these health statistics are to these simple changes in the question. Nonetheless, I think they are very important, because we need some statistics. But so this calculation of healthy life years is a comparatively young effort in demographic research, and I think in health research. And so we have to learn a lot. And I do not want to say that this is makes no sense, but we should be aware of the sensitivity. So this is an important point, so that the indicators we use should be chosen carefully, and we should be aware of these problems. So just to close this up, maybe I can come back to the gender differences later. I think we should speak anyway about this. So the question was coming to me from an Austrian journalist who was worried about the situation for Austria that Professor Simon mentioned, that they are so low in the ranking. And then I mentioned this example of Germany, and she did not believe me. And so she even traveled to Brussels to try to find out what is the point of view there. And she noticed, or she told me then, and there's also a nice report that the Austrians can read it in the journal. I think it was the Presse, but I can look this up. That they are not even aware of these problems. Yeah? So it's just they accept the statistics as they are, and I think this can be very difficult. Okay, but this is, I think now I really spoke enough about this question. How can we measure it, and how can we use it? So life years I still think is a very good indicator, but when we integrate health, it becomes very, very difficult.
Thank you, Dr. Louis. Thinking about all of your examples, I think it really nicely illustrates how we construct questions to either include or exclude these really important pieces of society. We talked about race, we talked about education and affluence, we talked about social connection, and now we're even talking about interpretation of what on paper may look like a straightforward question, but as you said, is very complex. And your example brought up for me is how we even interpret regular activities of life. And do we know that the threshold of participation and how that's normalized is healthy? Or is regular activities of life already unhealthy when we think about the extent of social isolation or mental illness or civic participation or all of these other things? And so I think it becomes really interesting to really be curious about how we do measurement in a way that captures these complexities. And I think the other thing that is really important is understanding who is in and left out of large administrative kinds of data captures. For example, I know in Canada, we have real challenges appropriately capturing information, accurate and meaningful information from our First Peoples and from new immigrants and from others who feel excluded from quote unquote normal society or settler society or colonialized society. And this is a real problem because many of the groups who are not appropriately captured in our chapter of health are the same who are experiencing the most profound inequity and structural barriers. And this, in some ways, perpetuates the problem. So knowing of all of this, I come to you with my third question, which is what knowledge, what skills, what experiences will be needed by our next generation to foster and sustain healthy societies in the face of our rapid technological, economic, and environmental changes that we're seeing happening globally. And this may be something we want to talk about in a disaggregated way, speaking to gender differences or other subpopulations. And out of fairness, Professor Simon, why don't we start it with you? And I'll let you hand off to whoever you like when you're done.
Good. I will start that I was thinking about this question. This is the most difficult one because we cannot say, I think. We can think about, in my mind, I think the most important is flexibility. And maybe I would use this as a synonym for resilience. I think we are in an age where, and this is both at individual level, but also at system level and country level. So I think what I would like to bring an example, in healthcare, very often services are centralized because they are efficient, you have the biggest expertise, and this happens very often. But then comes a shock like COVID, and if this one center crashes down because, I don't know, half of the staff, for example, gets ill, then this kind of service is non-existent over a period. And so I think we are getting into a new era where we have to add this kind of, we have to design our lives as individuals, but also our systems, whether it's healthcare system, whether it's transport, etc. Even our hospitals, in a way that they are flexible and they can adapt. And I think this is the most important. It's also in evolution. We see that it's not always the strongest which survives, but the one which can adapt best. And I think this is exactly for this generation and the future the most important factor. One very interesting thing, again, going back to healthcare, maybe just an example. Japan has possibly the highest number of hospital beds per 100,000 inhabitants. Nevertheless, they were running out and the healthcare system was not coping at some point, even though initially they were handling the pandemic very well. They were getting away with fairly limited numbers. And what turned out is that actually it's not the number of beds, but the number of intensive care beds that matters, and here there was no opportunity to be flexible. The system was, even though they had a lot of beds, they didn't have the relevant staff and the relevant flexibility to turn these beds. And I think in our healthcare system here in Austria, we also have many beds, many criticize this, whether it is good and efficient, etc. And I know I'm sticking to healthcare here, but I think this is the simplest example for also the audience to understand. but I think we have more flexibility as a result of this. And in this current pandemic situation, this is good. Obviously, hopefully, we will not have this so often that this needs to be sustained. But definitely, currently, this is a good aspect. Thank you. And I need to hand it over, but I would then say I will ask Sue Horton to continue, as I think we talked recently.
Thank you. So when I saw this question, I thought, wow, this question is just too hard. I can't answer this. And luckily, I'd run out of space in my number of characters by the time I got to this. So I'm going to give it a very simple answer that occurred to me. So on the one hand, you think of COVID, and you think of all the studies that are being published and the modeling that's been done, and it requires real-time artificial intelligence, big data, produce very quickly, huge teams, and you think, oh my gosh, I'm getting old. This is not the kind of stuff I was trained to do. And it's true that we need, physicists to do the modeling, the epidemiological modeling for COVID. On the other hand, I'm going to suggest something much simpler that it came out of the two examples I had thought about, one of which was race and one of which was age. And I think in part, the issues of data collection require us to not collect data about people, but we have to involve the communities themselves. So, I already pointed out a couple of times the issues with race-based data in Canada. That it didn't exist, for policy, for well-intentioned reasons, and you can see why. I mean, I had a really nice quote from something I read in the course of preparing for today, from someone from a journal who said, there's no use in collecting race-based data on crime in the US if you don't also have race-based data on sentencing and incarceration to back it up. That you can give false impressions by focusing on one set of race-based data, whereas the community itself concerned, would probably have a different opinion as to the areas in which we should collect race-based data on, discrimination, lack of access to healthcare, inability to get health insurance, etc. So similarly, I think the same thing applies for the elderly and vulnerable populations and those who face, for example, cognitive disabilities. We can argue, yes, we need to collect more data about older people. I mean, because in Canada, unlike in Austria, where you relatively managed to protect the older population, and from what I understand, the deaths of people in long-term care homes was less than 1 in 5. Whereas in Canada, it was more like 4 in 5. We're one of the few countries in the world where the COVID death rates have been higher in women than in men. There are only 13 out of 170 countries which have had higher COVID death rates for women. And Canada is sadly in that list because of the fact that the illness got into the long-term care homes, and we weren't aware of how bad the conditions were in terms of people sharing rooms, etc. So the Royal Society of Canada came out with a very interesting report, and the two last recommendations that they made were about inclusion. And they said, in collecting more data about the living conditions of elderly people, we must include them and their experiences in this, in order to get to be sure that we pay attention to the things that are important. Okay, so just related to this, one of my PhD students applied during the pandemic and said, look, my son has a member of a group that has cognitive disabilities related to a genetic condition. And what I'd really like to do is to quickly do a survey of the mental health of individuals living with this condition and see how COVID has affected them, how the lockdown has affected them. And so, I'm a health economist working on global health, but all of a sudden I had to learn about how can you do interviews remotely with a population that have cognitive disabilities, and also what is their capacity to consent. So it really opened a new world to me about thinking about involving those people, about whom we are talking and theorizing and, analyzing, that they also need a voice. So, I started out as a very traditional economist, and I've come to be much more a believer in mixed methods and complementing the work that we do by numbers with also people's experiences. I guess that's my simplistic answer to your elegant question. And I'm passing it to Dr. Louis.
If I may interject for a moment, Dr. Louis, while you're organizing your thoughts, I'd just like to remind the audience that shortly we'll be able to pose your questions to the panelists. So if you have any, please feel free to put them in the Q&A or F&A box at the bottom of your screen, and I will read them out to the panelists. And Dr. Louis, over to you.
Yeah, thank you. So I also have to agree that this question was extremely difficult to think about and to where to start. And but I started with exactly the point where Professor Horton stopped her statement at the end. So thinking about those about whom we are doing research, or the general public, so what they can do to foster healthy societies and to sustain healthy societies as a starting point. And I think a very important issue could be to raise the awareness in the general public, because according to my experience, it is not so present that most of the variation that we see in health and in longevity is due to non-biological factors, as I call it, or let's say to factors which are to some extent, so directly or indirectly, caused by human action. So I realize very often that people are surprised by the extent. So there are several studies with very different concepts who try to estimate this impact of biological and genetic factors versus non-biological factors. And they all arrive at this number of 25%. So that 25% of the variation, or up to 25%, is due to some biological genetic issues, but the rest 75% is due to somehow to human action. And the same number applies, now I can come back to your question, Professor Simon, about the gender gap. The same number applies, according to our research and research of others, to the causes of the gender gap in life expectancy. This is, as you said, in the moment 5 years. In the past it was higher. So it was already 7 to 8 years in Austria and Germany. In other countries it was even higher. Today it is even higher in other countries, even 13, 14 years in Eastern Europe. And but the studies clearly show that also these differences between men and women are to a maximum of 25% due to biological factors. So the question, if it's not biology and genes, what is it? So I do not start now with how can you separate between biology and non-biology. This is probably a discussion for an own panel. And it's also very complex because there are so many factors, behavioral factors. And but what we can say for sure, that there's one dominant factor inside that determines the most of the difference in the life expectancy between women and men, and also the trend, and this is smoking. And this is what we see now. You mentioned, Professor Simon, that we see that the gap in life expectancy is closing, above all in the highest ages, although it is not yet closed and it's still far away from closing. But even this is due to smoking. So we know that the smoking behavior, let's say, is distributing like an epidemic in the population, with this, like we see it now with the COVID waves. So that reaches some maximum point and then it goes down again. And typically men start some decades earlier than women. And consequently, the mortality consequences of smoking started early among men. And this is when this gap increased. And now it is decreasing because men started earlier with this decrease in the smoking prevalence. So the smoking related deaths are not rising anymore, they are decreasing, and among women they are increasing. And this is what is causing in the moment the gap. And we can in principle also forecast how long this trend will go, and that it will continue to to decrease. So just that I do not forget your question. So I would like to cite just quickly a colleague from Duke University, because I think he wrote a very nice paper that summarized this in a very spectacular sentence. The title of the paper even was that personal decisions are the leading cause of death. So when you think about this, is a very strong message, but he's speaking exactly about these factors that I mentioned: smoking, diet, criminality, alcohol, drug consumption, diet. And I just checked here the numbers, and he estimated with US data that 50% of the heart diseases and even 2/3 of the heart disease deaths, yes, and 2/3 of deaths due to cancer are due to this, what he calls this personal decisions. And what I found very interesting, that he also estimated that 95% of these deaths due to personal decisions result in the death of the person that made the decision. So I think that this is a very important knowledge, as you posted in your question. What would be very helpful if it is awareness that we can do really a lot about health and longevity is present in the general public, and there we can help, I think, a lot. Connected with a second information, and that is how high life expectancy in fact is. So also an experience from my research, but also from surveys where people are asked, what do you think, how high is life expectancy? So in those surveys, I know this number that people estimate is distinctly below the actual number of life expectancy. And we know that even the actual number of life expectancy is even a very low estimate, because life expectancy is, at least in the long run, rising and rising. That means this is also a very low estimate. So being aware first that we have a lot of more years ahead, most likely, than we think we have. And second, that we can influence a lot how healthy we are and how many of these years we actually have. I think this would be very helpful to, as you put it, foster and sustain healthy societies. And quickly, with regard to those who have to think about the measures, how can we help the population to become healthier or to invest in their health? I think an important point that has also been mentioned sometimes this evening or this afternoon in Canada is that we should identify the most vulnerable groups. So in principle, first, we should be aware that we can't separate the total population in different subpopulations. And I think that many subpopulations have very different health problems or ways how they can be addressed and how these populations can be reached. But most important would be the identification of the vulnerable groups. And then as the next steps, to identify the most important risk factors that cause the bad health, the poor health, and the high mortality of these vulnerable groups, combined with the development of strategies how to reach them and what are their problems, how can we help them. So to end with my thoughts about your last question, I think in this context a very important insight that we gained from research from many disciplines is that so that the most important factor, as has been mentioned, are social factors. So between all these kind of variations and differentials, there are always social factors that play a very important role. And this flexible resources that Professor Horton mentioned at the beginning, I think that this is a very helpful starting point to put in framework how we can develop measures how to help these vulnerable groups. But now to leave some time for the discussions, I stop here with my thoughts.
Thank you. While we're waiting for questions from the audience to appear in the question and answer box, I do want to say how inspired I am about all of your comments about intersectionality and how all of these factors influence and shape one another. I think that's really, really important. And building on your comment about how awareness of the determinants or non-genetic, non-biological determinants of health are so important, especially in terms of people understanding their own agency in how to shape their health going forward, is really also helping people to foster a greater awareness of what is an individual's responsibility versus what is a societal responsibility for creating the conditions that promote health, and what things that they can do for themselves, and what things that their choices about who governs them may help to shape. And I see your hand, Dr. Simon, so I'll come right back to you. And the example that comes to my mind is the availability of childcare, affordable childcare or accessible childcare as a determinant of things like education, ability to work, food security, housing security. These are really critical things that may seem like an individual risk factor, but are frankly a consequence of social decisions. So I will hand it over to you, Dr. Simon, while we're waiting for questions to come in.
Yeah, I'm sorry, I don't want, it was just really a continuation of what Dr. Louis said. It's about this choice, personal choice. And I think it's very important and people should understand, but we have to be aware, and I come again back to inequalities here, that we don't all have the freedom of choice. And this is where the capabilities approach I mentioned earlier, it's actually an approach which is trying to bring in this freedom concept in measuring well-being. And it's very important that it has two dimensions. One is our internal capability of making decisions, and the other thing is the external opportunities, whether these are given. And the measure we developed recently was translated to Chinese, and we were in very direct correspondence with the people who were kind of piloting it and translating. And there is one question there, that I am able to appreciate nature around me. And they said that the people struggled with this because in China you have these gigantic cities with literally no green space. And for an Austrian person with wonderful green spaces and mountains, this is given that we can enjoy nature. In China, people don't understand this question because they never had the opportunity to enjoy nature. I mean, obviously, I'm not talking about the rural, the city areas. And I think this is very important to understand, and this is where the politics and the government and the societal role comes in. We need to support people and the vulnerable, that they are able to make these choices, and we give them the opportunities for this. Thank you.
Thank you. That's a really elegant example. So I am watching the clock, and we haven't had any questions from our audience yet, but I will invite audience, if you have anything you'd like to comment on or ask our panelists, please feel free to put it forward in the question and answer. And while I'm leaving that open for you, I will invite each of our panelists, as we're coming to the end of our session now, to offer a very brief closing thought on, when you personally picture a healthy society, what do you see in your mind's eye? What is it that you imagine? I will fill air while you think. For me, I want to see a future where my children feel connected, have access to the things they need, and can experience joy in their personal lives and joy in their work. And as a public health researcher and public health professional, I think, what can I do to help build that for them? And so I'll leave it open to all of you to maybe share your imagination of what a healthy society looks like.
Shall I start with some?
Of course.
Yeah. No, I would have also liked to think longer about this question, but yeah. Of course, it's a question we, in some way, one way or the other, we are thinking very often about this. So I think what is still, at least in my in the context where I'm working, where I'm dealing with, is underestimated impact on health and longevity is stress. So I think that this is maybe even the risk factor number 2 behind smoking, maybe even stronger than obesity, which is generally seen now as the new risk factor number 1 for the near future. It will take over from smoking. But I think that stress, what is also a very broad concept, but this is playing a very important role. So when I first had this idea is, I mentioned this order member study already, where we found that above all, male order members are profiting very much from this monastic life. So their life expectancy is up to 5 years or even more higher than of the men in the general public. And I wanted to understand why, and I did not know where to start. So I went to the monasteries and asked them how they explain why they live so much longer. And what was interesting was that regardless with whom I spoke, if it was the abbot himself or the cook or whoever in the monastery, they all came up with the first, and that was from everyone the same, really from everyone, that it is the clearly structured day of life. So this daily routine that they have already, they were so happy that they do not have to take care to organize every day again, so that they know when they have to get up, when they have to pray, when they have to work. And when I thought about this, so I translate this into stress. So this is some way how the daily life is just reduced of stress, what we take normal, no? That we get an email, we have to change what we wanted to do and so on, and the next phone call is coming in. I never thought about the stress factors. And also the second reason, what most of the order members, not all, mentioned was that they said that this missing break in the life due to the pension. So for them, it was very important that they can all continue with an important function in the society, that they feel part of the society. And I think also this can be somehow translated with stress, when you have to define yourself new after the pension and to find new functions and so on. So a healthy society, I think, is, according to me, one where the general stress level is becoming less and less and significantly reduced. But this was a spontaneous thought to your question now. Thank you.
It was a spontaneous question. So, Dr. Horton, I see your mute is off. Did you want to go next?
If that's okay, Dr. Simon. It's interesting. The one thing about the life in the monastery is you have no stress because you have no children. But I think that's a really bad thing to miss out on. So I think it cannot be an ideal society. But you know, what you generated from it was the idea of stress. I think you're spot on there. So for me, some people, when you ask them, oh, what is your life plan, or what is your life plan for your research? I'm never able to answer that question. So I can't answer your question about what is my vision, my future vision. But what I can tell you is short term, because I've always been able to think of what would I like to do in the next 3 years or 5 years. It's more tractable for me. So the lessons I would draw about healthiness are related to COVID, because it's been such a big impact. So let me say 3 things that are good and 3 things, things that should be taken from COVID as good for going forward and structuring better things, and 3 things that we have to avoid. So the 3 good things are people have stayed home more and have spent more time out walking and in nature. My friends are always sending me pictures of birds that they've seen on Facebook, and we put a bird feeder out. So I think that's something I would like to continue more of, not just birds, but just generally being outside. That's been very healthy. We've all spent more time with our families and less with our friends. And there is this saying in English, God gave us our relations, thank God we can choose our friends. But actually family is very, very important. Maybe I'm saying this because my second grandson was born during the pandemic year, and I thought, oh, this is going to be just awful, having a baby in this horrible time. But no, it's been one of the biggest blessings. And I think people who are lonely and living by themselves, and young people who want to be dating, it's been extraordinarily hard, the pandemic, for them. And the third thing is, I think, work-life balance. On the one hand, working at home, we all tend to overwork and work too many hours and not take enough breaks. But the ability to be able to work from home is, I think, something that we will want to continue after the pandemic. And you see people like Google are saying, yes, you don't have to be here 5 days a week. We want you here, I think the Gates Foundation has a home week once a month where they want their staff to enjoy interacting with one another because there are big benefits from it, but equally avoid the stress of commuting. So those are the three good things that we could take towards a healthier society out of COVID. And what are the bad things that we should avoid? We've learned how bad inequality is and how strong the impacts of that are on mortality. We've learned that there are bad sides to globalization, to the fact that we've been so reliant on international supply chains for PPE, etc. And I think that's a big lesson we've all learned. All economists always say, globalization is a good thing, more trade is a good thing, and we've really hit the disadvantages of that in health. I mean, when the US, our wonderful neighbor, cut us off from PPE and has refused to allow us to get vaccines, but whilst they are sitting on stockpiles, that's not going to be happening in the future. I think many more countries are going to be, more self-reliant. And vaccine nationalism. I mean, let's hope we have less of that in the future. So those are my quick thoughts.
There is a comment in the chat I saw, so I would leave you to discuss the comment, and I will just make my final comment after that. Yeah.
Oh, thank you, Dr. Simon. So the comment in the chat is in fact a comment, and it says that there was a demographic study in Austria that showed that academics have a longer life expectancy, and our friends note that isn't this a comforting thought? It would probably also apply to the RSC in Canada as well, and what a positive perception for future collaboration. And I think it is a really nice thought, and one that shows the power of us coming together in a joint session like this. And yes, Dr. Simon, I will let you have the last word now.
Yeah, I will be short. I think on my side, I would have one wish beyond all what has already been said, and maybe it's just a continuation. I really hope, while digitalization is wonderful, we learned how good it is, we can talk to each other in this session across oceans and continents, etc. We can have homeschooling even under pandemics, and the children can learn again. But I really hope that at some point human contacts, and this is going back to the young people, and human touch, etc., will come back to our everyday life. And this would be my short, mid and long-term hope, that digitalization will not take over, and our children will also experience what we experienced when we were younger. Thank you.
Thank you. Yes, I feel like our understanding of the virtual world and the real world has really changed in COVID, and it's really, really important, especially for youth who are so virtual worlds are so normal for them, where it came later in life for some of the rest of us. So I'm noticing we have 1 minute left in our time together today. That went by so quickly. I thank you all for this rich and spirited discussion and the exchange of ideas. It was a really wonderful way to spend 90 minutes. And as we close, I want to thank both the Austrian Academy and the Canadian Academy again, and wish you all a very wonderful day in Canada and evening in Austria. Thank you all so much.
Thank you very much for wonderful sharing as well.
Oh, thank you.
Thank you. It was a pleasure to meet you. And hopefully we will also meet in person somewhere. But it was really a very nice sharing. Thank you very much, and very interesting discussion. And thanks for meeting you.
Thanks, Dr. Simon, you were exactly right. And normally we'd be all able to go out for a lovely dinner now and enjoy some wine and some good company. And the next time, until next time.
Yeah, hopefully. Bye-bye.
Bye-bye.